Good morning. Welcome to another session of critical appraisal series under short course in clinical epidemiology. This week it will be a critical appraisal of a diagnostic study, and it is my pleasure and privilege to welcome Professor PEEDICAYIL. Sir, thank you very much, sir. Sir needs no introduction. Sir has been our previous head of clinical epidemiology unit and senior professor, previous head of gynae oncology, and sir has been continuing to patronize all our activities and has agreed to come to most of our sessions. Thank you very much, sir, once again. And today's presenter will be Dr. Hallel Reba. She is a consultant in general medicine, and she'll be appraising a diagnostic study. And we'll welcome all your questions as well. And sir will chat the session. Thank you so much, sir.
Thanks, Vignesh, for calling me. It's really a privilege for me to be here and listen to and Reba present. So after she finishes, the floor is open for discussion.
Good morning, everyone. For today's clinical epidemiological session, we'll be critically appraising a diagnostic study using the STARD guidelines. So the outline of the presentation will be as follows. We'll have a brief introduction. We'll just cover the basic biases which we can expect in a diagnostic study, look at case scenario, and we'll critically appraise this paper which is there by using the STARD guidelines. So when we're critically appraising a diagnostic study, there are essentially three questions which we want to answer. The first question is the study valid? The second question is the study accurate? Can it distinguish people who do and do not have the disease? And the third thing we want to know is, can this study be applied at the bedside towards the patient to help us in clinical diagnosis? The index test is basically the test for which we are assessing the performance in comparison to a reference standard. So when we look at the results of an index test, there are under two parameters. One is look at the accuracy of the test, that is the sensitivity and the specificity. And the other parameter is how well it predicts the risk of a disease in the population being tested. For that, we use predictive values as well as likelihood ratios. Now, sensitivity is the true positive divided by the total number of patients who have the disease. Specificity is the true negative among the patients who do not have the disease. And if you look at it horizontally, we can calculate the positive predictive value as well as the negative predictive value. It's important to remember that sensitivity and specificity does not depend on the prevalence of the disease in the population, but the predictive value depends on the prevalence of the disease. Now, what is a positive likelihood ratio? It is the probability of a person with the disease being tested positive divided by the probability that a person without the disease gets tested positive. The formula is sensitivity divided by 1 minus specificity. The negative likelihood ratio is the probability of a patient, that is the person who has the disease, being tested negative, divided by the probability of a person without the disease being tested negative. So the negative likelihood ratio is 1 minus sensitivity divided by the specificity. Now, when we do a diagnostic study, there can be some biases which come up. It can be in the part of when we do the patient selection. It can be when we're actually assessing the index test. It can be when we're verifying the disease. So when you do a patient selection, there are two biases. One is the partial verification bias. The second bias is the spectrum bias. If you look at this first picture, all the patients who undergo the index test undergo the reference standard. So this is a index test which has undergone complete verification. Sometimes patients undergo index test, but not all of them end up with a reference test. So that results in a partial verification. For example, the most common example is when we're sitting in an OPD, an elderly gentleman comes for evaluation of altered bowel habits and some loss of weight and loss of appetite. We're actually worried about GI malignancy. So if the patient has financial constraints and time constraints, what we normally order in the OPD would be, if we say an anemia, we'll order a stool local blood. If the stool local blood becomes positive, then we definitely urge the patient to go ahead with the colonoscopy. Suppose stool local blood becomes negative, we might wait and watch. So then this partial verification happens if we're going to do a test or do a study to actually look at the diagnostic accuracy of the stool local blood. So for example, if I had taken 330 patients who underwent stool local blood test, and out of it 150 of them had undergone a colonoscopy and were later confirmed to be having malignancy or no malignancy. Out of the 150 patients who underwent the colonoscopy, 100 of them had malignancy. and 50 of them did not have malignancy. Now, if I look at the sensitive stool of a blood, I would probably have 80 patients that be false positive. So 80 divided by 100 would give me a sensitivity of 80%. If I do a retrospective analysis by looking at the chart and see how many of them underwent a colonoscopy and then look backwards. But if I do the test correctly, that is, I look at all the patients who had undergone stool occult blood first, and then I see their results, and out of it, how many of them ended up having malignancy, then my sensitivity change. So if I go the other way, if I had taken all the 330 patients under the index test, out of it, 80 were positive, and 80 of the stool occult blood were negative. Now, if I calculate sensitivity, it will be 80 divided by 160. Now, sensitivity falls at 50%. So that is how a partial verification bias happens. So how do we correct a partial verification bias? We must always include the patients who underwent the test, the index test, irrespective of their outcome. Now, the next set of bias which can happen is a spectrum bias. So we know in any disease condition, there's always a disease severity. Patients can be mild, patients can have moderate illness, patients can have severe illness. Now, if I design a case control study, I'll give another example. Suppose we are evaluating a rapid antigen test for COVID-19. Okay, so the manufacturer is saying that this test has 98% sensitivity and the test has 99% specificity. And if you actually look at the methodology, what they've done is they've done the study in patients in the ICU who are COVID positive. And for the reference, they have looked at the patients who are gone home who are COVID negative. Now, what happens is we are having the sickness of the sick patients and we're comparing them with the fittest of the fit patients. So the sensitivity will increase. What about the middle population who are admitted in the ward, who are not too sick? We want to actually assess if the test is coming positive in these patients. Because we're excluding these intermediate patients, we're actually having a bias where we can have a falsely elevated sensitivity. The next spectrum bias comes when you're dropping indeterminate results. For example, if the test is positive, if it has 2 lines, and the test is negative if it has only 1 line. Sometimes you might have some conditions where we don't really know if the second line is positive or negative. It's a very faint line. So what do you do with that test? Do you label it as positive or do you label it as negative? Or do you just exclude it? So if you exclude it, what happens is, it can increase the sensitivity. Suppose the patient actually had a mild disease and I falsely interpret it as negative. Then what happens when I discard that sample? I'm actually discarding a false negative sample. So my sensitivity will increase. On the other hand, the patient didn't have the disease, but when I'm looking at the indeterminate result, I might have labeled it as false positive. Then if I exclude that sample, the specificity of the test will increase. So that's how you get the spectrum bias by dropping indeterminate result. And the same thing happens if you do convenient sampling also. Suppose I want to do an ultrasound just to look at the B lines in a patient who has acute decompensated heart failure to look for pulmonary edema. Suppose the patient is very obese, and then I look at the patient and decide I want to recruit this patient for the study because it's going to be very difficult for me to actually assess the patient's B lines. Then what happens? We're excluding a patient and we don't know whether the patient actually has some heart failure or didn't have heart failure and how we would have interpreted intervals. So these are some ways by which we get spectrum bias. Now we can also have bias when we are interpreting the result. Same way. So when you're interpreting and you see an indeterminate result, you can dichotomously label it as positive or negative. So based on how you categorize it also, you can have bias. Second thing is the reviewer bias. Suppose I'm looking at the result of an index test, but I already know what the reference standard was, then I'm already biased towards the result. So this is where the STARD guidance come into action. So this was actually developed in 2003 and it was further developed in 2015 and has come out. So basically it helps to improve the reporting methods when you are reporting a diagnostic study. And it increases the transparency so that as reviewers, when we're looking at the study, we can actually look at the biases. And the third thing is when we are planning a diagnostic study, we can actually incorporate these tools to minimize the bias in our own methodology. So let's look at 2 cases. So we're sitting in a health camp and we get a 6-year-old child with failure to thrive. He appears malnourished and he presented to the health camp with cough for 3 weeks. Will you treat this child for TB? Then the second case is a 10-year-old child who presents with cough for 3 weeks. There is some family history of his mother having a recent contact with pneumonia. Now she's well. Now will you treat this child for TB? So I wanted to, so the paper that we're critically appraising is basically the diagnostic accuracy of the 3-gene host response cartridge system. But before going on to the paper, I just want to give you a brief background about the study. So this paper was published in 2023. It's called the Rapid and Accurate Diagnosis of Pediatric Tuberculosis Disease. It's a diagnostic accuracy study for pediatric tuberculosis. So this is the study protocol, and for short, it's called the RAPEED study. So basically, they have taken 1,000 children with presumptive TB in middle and low income country, that is in Africa and India, and they did a diagnostic workup. They looked at the child's history and clinical examination. They looked at microbiological tests like the expert ultra and the TB culture. They looked for any evidence of TB like skin test and IGRA, and they clinically assessed the child and also looked at the X-ray. And they followed up these children, and they have finally labeled them as confirmed disease, unconfirmed TB, and unlikely TB. And if you look at what they have done, during the initial assessment, they have taken informed consent. They have applied the question literacy examination. They have done all tests for TB, than microbiology, that is culture and ultra. And they have also done some experimental tests on these children, and they have followed them over time intervals. 1 month as well as 3 months. And if the child was on medications for TB, they followed them up for 6 months and every month. And so these are the novel assays they have also looked at the baseline. They have looked at the stool expert. They have taken finger stick blood to look at the host response prototype. They have taken some blood samples to look for T-cell activation marker. They have taken urine samples to assess 2 urine assays, that is the detection of lipoarabinomannan. And they've also taken blood to look for the proteomic signature. But we'll be concentrating on the results of the second test. So the article which we'll be reviewing now is called the Diagnostic Accuracy of a 3-gene Mycobacterium tuberculosis host response cartridge using finger stick blood for childhood tuberculosis. This is a multi-centric prospective study in low-income and middle-income countries. So we'll be appraising using the STARD guidelines, and the checklists are also being distributed. So if you look, it has basically 30 items. So the first and second item basically covers the title and the abstract. Now, based on the title itself, we know that the study is a diagnostic study. It mentioned in the article. So the first question is yes. Second question is, do they have a structured summary of the study designs, methods, results, and conclusions? They do. This is the abstract of the study. There is another checklist to actually appraise abstract. That's called the STARD. And when we applied it to the abstract, it actually has reported quite well. The study objectives are mentioned, how they have collected the data, whether this was a prospective or retrospective study is mentioned. They have mentioned the eligibility criteria. The only thing they haven't mentioned is how they had recruited the participants, whether they constitute a random or convenience sampling. They have described the index of the reference standard, and the total number of participants are also mentioned. And they also haven't mentioned the registration number as well as the name of the registry. Now, the item number 3 and 4 basically covers the introduction. It looks at the scientific and the clinical background. It includes the intended use and the clinical role of the index test, and also the study objectives and hypothesis. So the MTB host response test measures the levels of 3 genes. These are the 3 genes that have studied. The guanylate binding protein, as well as the dual specificity phosphatase 3 and the triple-like factor. So in patients with TB, what happens is the mRNA expression of these 2 genes increases and the mRNA expression of this gene decreases. So based on it, they calculate a score and then they interpret the results. And the test uses the gene expert platform to analyze the blood sample, and they calculate the cyclic threshold of the 3 genes. And this actually has shown to be different in other diseases as compared to TB. So they were thinking that this test can be used actually as a diagnostic test as well as a triage test. And they can actually use it to monitor the response of the disease. So when the patient is getting cured, maybe the gene expression levels will also change. So the objective of this study was to assess the diagnostic accuracy of the TB host response prototype in children with presumptive tuberculosis. They had not mentioned any clear hypothesis statements. So the population studied of children presenting with presumptive tuberculosis. The index test was actually developed by the Cepheid company, and the reference test they had actually taken 3 references. The first reference was a culture confirmed tuberculosis. The second reference was any microbiological confirmation, either expert was positive or culture was positive. And the third was the composite clinical reference standard, where either the clinically patient looked like TB or the microbiology was confirmed. And the outcome they looked at was sensitivity as well as specificity. So this was the setting. They had done in tertiary hospitals in South Africa, Malawi, and actually CMC was one of the sites this test was conducted, as well as in Tanzania and Mozambique. The next items 5 to 18 basically covers the methodology section. So the first question is whether the data collection was planned before the indexes and reference standard were performed. So it's clearly mentioned that this is a prospective study. Now the next thing is what was the eligibility criteria? So the inclusion criteria included any child who was referred to our center who was already confirmed with TB, either by expert or culture. Second thing is whether the child had latent TB, like tubercle skin test was positive or Ibra was positive. Third thing was whether the child had signs and symptoms of TB. The exclusion criteria they had ruled out was all sick patients who could not undergo those initial tests, and when the body weight was less than 2 kilos, age more than 50 years, and if any child had already been started on anti-tuberculosis therapy. So this is the full inclusion and exclusion criteria, which is very good. Actually, they have taken confirmed TB, and they have looked at all the signs of pulmonary as well as extrapulmonary disease. For pulmonary disease, chest X-ray suggested of tuberculosis, any weight loss, loss of weight, persistent cough, as well as symptoms of extrapulmonary TB like enlarged lymph nodes, painful enlarged joint, pleural effusion, pericardial effusions, and signs of CNS TB, either based on the CSF findings or based on palsies, oculomotor nerve involvement, or patients having convulsions and meningism. Okay, so the next question is on what basis potentially eligible participants were identified, such as symptoms or results from previous tests. So we didn't have a registry. All our patients were basically identified on referral, like either because of test positivity or based on symptoms when the clinician suspected it. So items 8 and 9 basically talks about the setting, location, and the dates, and how the patients are recruited. So if you look at the study setting, in Tanzania and Mozambique, it was an urban comprehensive health facility, tertiary hospital setting in South Africa, Malawi, and India. And in India, actually, we did only inpatient recruitment. And outpatient recruitment was done in Malawi, Tanzania, and Mozambique. And the study recruitment was done between Jan 21st, 2019 to June 30th, 2021. Actually, in this paper doesn't really mention how the patients were recruited. The paragraph just mentions that recruitment of children was conducted with collaboration from the National TB Control Programs. But however, they had published another secondary analysis paper. That one it mentions that the recruitment was constituted. This one line was mentioned. So were the index test and reference started in sufficient detail to allow replication? Yes. So if you look at how they've done the reference standard, so at the baseline, they have taken respiratory samples. Either SS stands basically for spontaneous sputum, or they've taken induced sputum, or they've taken gastric aspirate for the children. And if the child was less than 5 years, they've done a nasopharyngeal aspirate. And they've taken 2 samples. So the first sample they have split into 2. One half of the sample was sent for ultra, other half of the sample was sent for cultures. The entire second sample was sent only for cultures. And if the sensitivity was positive, the test became positive, then they did the AFP staining as well as they sent it for line probe assay. Okay. So now then they had diagnosed the patients based on the classification from the US National Institute of Health consensus statement. So confirmed TB was MTB to be confirmed by culture or ultra. Unconfirmed TB was pathologically not confirmed, but they had signs and symptoms of tuberculosis. Like the patient had cough for more than 14 days, failure to thrive, lethargy, or radiologically positive or immunologically evidence of TB. Unlikely TB was if there was no pathological confirmation and the patient did not have the criteria for unconfirmed TB and the TB treatment was not received. But the only problem is, what about the children with negative response to TB treatment? So here you can see unconfirmed tuberculosis. They have a positive response to TB treatment, but they have not mentioned what will happen to children who didn't respond. Would they be classified as unlikely TB or were they just eliminated? So that was not mentioned. So based on the clinical data, the lab data, and the radiological data, the site reviewer would classify them as confirmed, unconfirmed, or unlikely TB. For radiological data, they got a special confirmation by using two independent radiologists who were blinded to each other's results or each other's interpretation. And finally, at the end of it, to add extra confidence to the review process, they have taken two independent endpoint review committee members, and they would label the children as confirmed, unconfirmed, and unlikely TB. Suppose they both had disagreements, a third reviewer was asked to review, and the majority was taken as the classification. Now, how do they do the index test? So they did the index test at the baseline at 1 month as well as at 3 and 6 months. They would take finger stick blood samples of 100 microliters and they would instill into the cartridge and the gene expert platform within 1 hour of blood draw, and the result would be available within 1 hour. The problem was actually the cartridge became available at the end of 2019, but the study was started at the beginning of Jan 2019. So the previous samples are all kept in this buffer, Pastine buffer, and stored at minus 80 degrees Celsius. And then once the cartridges are available, they were processed freshly on site. And they would calculate the CT values, and based on that formula, they came up with a score. Score less than 1.5 was positive for TB. So we can see that already now there is a possibility of a measurement bias because now we have a batch effect. We have fresh samples, we have stored samples. The third thing is, what was the rationale for choosing the reference standard? So the strict reference standard was culture positive for NTB. Composite microbiological reference standard was either positive ultra or culture. Composite clinical reference standard was confirmed TB plus unconfirmed TB, that is based on history. Now, we have taken 3 reference standards, but you should understand that TB doesn't really have a proper gold standard. Each of these reference standards have their own advantages and disadvantages. I just listed out a few. Culture is rarely false positive. That's good, that's the advantage of culture. But what's the disadvantage? It has a very low yield. The sensitivity is very low for a culture. Plus, it skews results towards patients who have a multibacillary disease. Ultra is good because it has a higher sensitivity, but we also don't have, the specificity is not fully 100. The composite clinical reference standard is actually what clinicians want to know. In patients who don't have culture positive but who have symptoms of TB, we really want to know if this new diagnostic test can actually pick up TB in these patients. So it's very good that they have included this composite reference standard. But you should understand that the disadvantage is it has basically combined already existing imperfect tests. And one more thing about unconfirmed TB is there's another study which was published in Peru. So they had followed up 35 children who met the definition for unconfirmed TB and they had followed them up. And you can see 35% have enrolled. And after say 16 months of following them up, 5 of them had developed radiography findings of TB, but finally the clinician had decided to start TB treatment only on 2 patients. So even though we have unconfirmed TB, not all of them probably actually have TB. Okay, so the next question is the definition of and rationale for test positivity cutoffs in the index as well as the reference test. So in this index test, they had used a cutoff of 1.5, which is already pre-specified. So where did they get this 1.5 value from? There was a published, Sutherland JS had published a study in 2022, the interim analysis of their study. They had applied the same post type this cartridge on adult patients. And they had got an AUC of 0.88 with a sensitivity 80% and 94% specificity in an adult population. So based on that, they had applied the Luden's index and they got the value of 1.5, hoping that the test would have a sensitivity of 90% and a specificity of 70%. The next question was whether the clinical information reference standard results were available to the performers or readers of the index test, and whether the clinical information index test results were available to the assessors. So in the material is written that the lab staff were marked to the clinical findings and the clinicians were marked to the MTB-HR results. And the staff conducting the new tests were blinded to the diagnostic classification of children. So that's been reasonable. The next items from 14 to 18 basically talks about the analysis. So they have done, so these are all the tests they have done to do the analysis. So they calculate the diagnostic accuracy using those 3 reference standards I just mentioned. And between the diagnostic category, they have used a man-with-me test to interpret the MTB-HR renal transcripts. And they have done the area under the curve to determine the accuracy of the score. In between group analysis they had used a D-long method. And all the sensitivity specificity was calculated using a cutoff of 1.5. And to explore on the ROC curve different any new value they can use for the cyclical threshold, they have used the Luden's index. And they also want to compare the time point of the score. For that, they had used the one-way repeated measures ANOVA with pairwise pair T tests. And they had also done the random effects meta-analysis to look upon the heterogeneity between the test sites. Okay, so the next question, important question is how the indeterminate index test or reference standard tests were handled and how is missing data handled. Now, in the study, there is no mention of any missing data at all. So they have not even told us how it was handled. They have written that samples with indeterminate results were completely excluded from the analysis. So that is also will result in some bias. They already had some pre-specified subgroups that they wanted to analyze. That is infants younger than 1 year, children with severe acute malnutrition, and children living with HIV. And to look for any variability, they have used the D-long method to compare ASD within groups. So how did they calculate the sample size? So they had wanted at least 250 patients with confirmed TB, so that the sensitivity of 82% with a 90% power with a 95% confidence interval. So this 250 participants will also help them will be powered for the subgroup analysis. It's important to note that the WHO target product profile, basically the WHO is trying to design new diagnostic tests for TB diagnosis. They want at least a minimum sensitivity of at least 66%. So now we move on to the results, that is from items 19 to 25. So the first thing is the flow diagram. So if you have seen, they have taken 5,313 potentially eligible children. Out of it, 4,330 were not recruited. Why? 4,091 did not meet the inclusion criteria. 124 did not provide consent. 123 of them were out of the catchment area. And only 975 were eligible. Out of it, 191 didn't undergo the index test. Now, why didn't they undergo index test? They have actually accounted for only 116 of these patients because they said that the sample was lost in the Malawi site. But what about the rest of the patients? Why didn't they undergo the index test? Some of the reasons I thought was probably because the study equipment was not available, or there was equipment failure, or patient might have refused the finger stick test and agreed for only the culture, like the sputum test. Or was there a problem with the investigator error? Like, did they forget to do the finger stick test? I'm not sure. So it's not mentioned in the study. So finally, only 784 of these patients underwent the index test. And among them, 7 of those results were inconclusive and they were excluded from the analysis. So 609 of them were index test negative, 168 were index test positive. The other interesting thing I noticed was 118 of these patients and 20 of the positive patients, they didn't actually, when they applied the reference standard, they could not actually categorize them as either confirmed TB, unconfirmed TB, or unlikely TB. So they have just excluded 17.6% of them off. So if you see actually the original study, the first protocol which was published in 2023, they have mentioned that 97.5 were enrolled, 965 of them had valid microbiological tests done. And out of it, 25% had confirmed TB, 29% had unconfirmed TB, 46% had unlikely TB. This is what they had mentioned in the first study. But here suddenly there are 17.6% of the patients are not accounted in that original study protocol. So that is that original thing. So I don't know what happened to these patients. So finally at the end of it, we have 639 patients, out of which 202 are confirmed TB, 230 have unconfirmed TB, and 207 have unlikely TB. Based on the original protocol, we have 239 confirmed TB, which is almost similar to 202, only 50 difference. Unconfirmed TB is 282 and 230. Unlikely TB is significantly smaller. You can see 444 in the original paper, but then now we have only 207 unlikely TB. So this can inherently inflate our sensitivity. So based on this, now we have strict reference standard. That is only culture positive, we have 127 patients. Both culture and ultra positive, now we have 202 patients. And the clinical reference standard, we now have 432 patients. So this is basically the demographic and clinical characteristics. You can see that India has contributed about 13% to the whole sample size. And most of the children in the study population actually were age group of 5 to 14, 20%, 32%. And the other thing was 11% of the patients in this cohort were actually had severe malnutrition, 14% of them had HIV. And among patients with confirmed tuberculosis, 21% of them had mild TB disease, And in unconfirmed TB, 38% of the patients had mild TB. So based on the, they have not given a table, I've just made a table from the results. So when you compare the score with the strict reference standard, we get a sensitivity of 59.8% and a sensitivity of 90.3%. And the area under the curve is only 0.85. But when you're using the microbiological reference standard, that is ultra or culture positive, the sensitivity has fallen down to 41.6%. And when doing the clinical reference standard, it's further fallen down to 29.6% sensitivity. So this is basically a range out plot. So this is patients with confirmed TB. This is patients with unconfirmed TB in the strict reference standard. So this bar is basically the median and the interquartile range. That's the box, sorry. The bar is the 10th and the 90th percentile. And they have also stratified it. The red bar is basically the biobank sample, that is the preserved sample. And the blue one is the fresh sample. You can see that the CT value is definitely different in both the batches. So when they had done the analysis, they had used a correction factor and they had corrected for this batch effect. And they have plotted the ROC curve, and the area under the curve for TB score was 0.846 when we used the strict reference standard. This is the plot for when you're using the modified microbiological reference standard as well as the clinical reference standard. In everything, you can see that the patients who had a fresh sample, the CT values are higher as opposed to the patients who had a frozen sample. So this was basically using the strict reference standard. They had looked at the subgroup interest. They had wanted to look at the age group less than 1 year. They wanted to look at the malnutrition status. And they also wanted to look at based on the HIV status. And they actually found that none of them were really significant. And in fact, the patients with HIV positive, actually the sensitivity was lower than in the patients who were HIV negative. So then they had also done a different subgroup analysis. So they had also looked at the tuberculosis severity. They found that the sensitivity was more in patients with severe TB, that is 64.7%, as compared to non-severe TB, which was only 42.9%. And the interesting thing was actually in patients with lymph node TB as well as extrapulmonary TB, the sensitivity was higher actually, as compared to the pulmonary sputum samples. Okay, so in the study, they have mentioned only sensitivity and specificity. I've just tabulated so that we can also look at the positive predictive value and the negative predictive value. So when we use the strict reference standard, we get a sensitivity 59.8, specificity 90.3. The positive likelihood ratio comes to 6 and the negative likelihood ratio comes to 0.6. For us, actually, as clinicians, we actually want to look at this table, which is basically the clinical reference standard. But here we find that sensitivity is very poor, which is only 29.6. And the positive likelihood ratio is 2.9. Ideally, for a test, we would like the positive likelihood ratio to be closer to 10. And for the negative likelihood ratio to be less than 0.1. Here it is around 0.7. The other interesting thing they had done is they had basically compared the results during the course of the treatment. And what you can find is actually the CT value actually is increasing as the months go by. So maybe we can use this test to actually see what is the treatment response. So finally, coming to the discussion, that is the study limitations. I would say that the study was done in patients who we suspect highly TB, like for example TB. So actually, this can actually overestimate the sensitivity itself. Number one. Second thing, we know I had explained about the measurement bias. And third thing is we don't have a perfect gold standard in TB. So any diagnostic test in TB actually has that disadvantage. And implication for practice is because already one study that was a Vellore study, definitely it's applicable to our population. And because this study has a rapid turnaround time less than 1 hour, it might have a role in at least diagnostic. We can't use it as a screening tool because the sensitivity is too low. And the last part of the study checkline, just look at the other information. So the study was registered on the clinical trials government, and the study protocol and methods are freely available online. So these are all the funders for the study, and none of them had any role in the study design, data collection, data analysis. The kits were actually supplied by CETI, and they actually were allowed to comment on the manuscript, but they didn't have any thing in the manuscript writing. So what is the point of doing a diagnostic test? Finally, it helps us to, we need to basically apply this to the patient. So this is done by the Fagan's nomogram. So first case, coming back to first case, the 6-year-old child, the failure to thrive, he appears malnourished, present to a health camp with cough for 3 weeks. Now, what is the pretest probability that this child has TB? 80%? Okay. And based on our looking at strict reference standard, we got a positive likelihood ratio of 6. So we have a pretest probability of 80. Our positive likelihood ratio is 6. Now, when I draw a line, we find that the post-test probability goes above 90. So it basically helps us to confirm that this patient most likely has tuberculosis. But suppose on this patient, when I had applied the test and it had become negative, now what do we do? So we have a pretest possibility of 80. We have a negative likelihood ratio of 0.6. So 0.6 is here somewhere. When I apply it, my post-test probability is still 70. So will you treat this child even though the test became negative? We should. At least we should evaluate. What about the second child? This is a 10-year-old child who presents with cough for 3 weeks. And there is recent history of mother having committed for pneumonia. What is the pretest possibility that this child has tuberculosis? About 50? Okay. Okay, 50 or 40. And suppose the test had come positive, our positive likelihood ratio would have been 6. So now I have a post-test possibility of what? 60, 70. So should I be worried that this child could have TB? Yes, so we will evaluate further. We won't ignore it. Suppose this test had come negative on this child, 50, and now we have a 0.6. Our post-test probability is 30. So that's how we apply the Fagan's nomogram.
Maybe we should apply the clinical STR.
Yes.
Not the first one.
Yes, that is really low. We can apply that and see. So the positive likelihood ratio on that was only 2.7. So yeah, so 50 and then 2, it comes to around 50. Thank you. I would like to thank Dr. Vinesh for helping us, and Dr. Kambu and Dr. Abraham for moderating the session.